Hi, I'm Ken Howard, and welcome to the Gay Therapy LA podcast. Today, I want to talk about mental health aspects of sexual health for gay men. So as a gay men's specialist, psychotherapist, and coach now for 30 years in 2022, and as a certified psychiatric social worker, and now ASECT, American Association of Sex Educators, Counselors, and Therapists, in the United States certified sex therapist, perhaps it follows that I might be interested in sharing some thoughts about the intersection of psychiatric disorders, physical and mental, sexual health, and their representation in gay men. Some of my recent sessions with clients in my private practice illustrate this intersection. So, I previously talked about the 6 principles of sexual health, coined by Michael Vigorito, LCSW, and Doug Braun-Harvey, LMFT, in their great book, Treating Out of Control Sexual Behavior, which was a book that addressed the controversy about sex addiction and offered a different way clinically for therapists and their clients to look at that. But I applied those 6 principles of sexual health in general, more specifically to gay men in a previous episode and also in a blog article on gaytherapyla.com/blog. But now I want to examine more closely the specific mental health or psychiatric aspects of a discussion of sexual health, especially for gay men. Because even in sexual health discussions, gay men are still underrepresented in the clinical and academic literature, and certainly in clinical practice training for all forms of psychotherapists. So my background as a certified psychiatric social worker, which was part of my graduate training as an MSW, Master of Social Work at USC, not South Carolina, University of Southern California in Los Angeles, led me to work with people who have severe and persistent mental health disorders. And these are cataloged in the DSM-5, which is the Diagnostic and Statistical Manual of Mental Disorders, 5th edition. That is published by the American Psychiatric Association, the most latest version in 2013, the 5th edition. And that's really the Bible of mental health disorders, where recognized psychiatric conditions are cataloged, especially for implications for insurance billing and really clinical acceptance. And these are disorders that often, not always, require what we call psychopharmacological, intervention, in other words, taking meds. So when someone has a diagnosable psychiatric disorder, and just a reminder, sex addiction, love addiction, porn addiction are not legitimate recognized clinical diagnoses. It's possible that they experience not only difficulty in their social or occupational functioning, which the DSM requires for it to be a disorder. If it's just a little neurosis and no harm, no foul, that's fine. But disorders have to cause either social or occupational functioning impairment in order to be considered a disorder, and quality of life, but more difficulty more specifically in their sex life. That's what I want to focus on today. So one of the mantras I use in my practice for what I do is helping clients improve their quality of life by way of improving the quality of their sex life. Although the majority of my clinical practice in therapy and coaching is actually not sex therapy. I do it, and I do a lot of it, and there's a lot of call for it, but what I tend to do more in my practice is about gay men's interpersonal relationships and career improvement, which I provide a lot of therapy and coaching for worldwide, just in different ways, from gay men all over, at this point, the planet. So one of the lesser discussions when someone sees a psychotherapist and or a psychiatrist, which is a type of MD, medical doctor, for help with a diagnosable psychiatric disorder, is about their sex life. That's not discussed as much as probably it should be when a lot of psychiatric disorders influence your sexual health or your sexual functioning. So the notorious side effects of the use of SSRI antidepressant medications, it stands for selective serotonin reuptake inhibitors, meaning that if you manipulate the serotonin in your brain, it very often will have an antidepressant effect. There's many drugs in that SSRI antidepressant family. But the side effects very commonly discussed for men can include delayed ejaculation and or diminished libido. And these are far too often dismissed by their prescribing physician, especially for gay men whose sexual activities are very frequently ignored or in some way discouraged by their physicians, unless they're gay identified or gay allied, which is more rare than you might think. This is why so many gay men come to me with these concerns, because they often feel unheard or somehow made to feel uncomfortable talking about their sexual concerns with straight identified providers, especially female ones, or even gay male providers who aren't specialists in gay men's mental health and sexual health, which I find especially unfortunate within our own community. But I see it often, especially around gay male sex addiction therapists, so-called, with so much internalized homophobia and heterosexism, or they're inappropriately acting out their rage through their work against previous partners who betrayed them and by breaking a monogamy agreement. And it's like, keep that stuff out of your work, guys. You don't want to... We all have biases, and it's important to be aware of them as providers. But, we don't want to carry too much of an agenda unless it's an agenda that supports the client, like the dignity and equal rights of gay men. So too often therapists in the sex addiction world label their clients, and they're trying to punish others by punishing their client for being a philanderer or a sex addict or a slut or whatever. And I just think that has no place in legitimate therapy, especially when gay men take so much crap for being gay in their sex life anyway. So let's fix that now. Let's discuss some very common psychiatric diagnoses and the sexual health aspects of them, based on some of the real cases that are disguised, however cleverly, for confidentiality from my daily 30-year practice with gay men. So let's look at some of them. Number one on our list of about 7 is depression. Part of the symptoms of clinical depression or major depressive disorder, mild, moderate, or severe, with or without psychotic features, as the DSM would say, is an impact of diminished involvement in pleasurable activities. That's one symptom of depression. It's also known as anhedonia, without pleasure. A hedonist is someone who lives for pleasure. So anhedonia is the clinical term for without pleasure in depression. Nothing seems fun anymore. Someone who is depressed might have lost interest in sex, or they are even more depressed that their depression keeps them from feeling horny or able to function sexually through arousal and erection and orgasm and the interpersonal aspects of those. The social withdrawal symptom of depression can cause the client or the patient, I use those terms interchangeably, to socially isolate, giving them fewer opportunities to meet dates or sexual partners in the first place, or to be sexual even with their own long-term partner. If they receive a medication that is designed to help their depressed mood and improve functioning, like being able to go to work, they might be depressed again that while the medication works for their mood, the sexual side effects are the price they pay for it. And it can be a vicious cycle that makes a guy feel stuck between a rock and a, not so hard place, let's say. So what are the solutions? For each of these on the list, I'm going to offer some solutions. So we don't just want to raise the problem and define it. We want to talk about how, at least a little bit, some of these problems or challenges might be mitigated. So in depression, some of the solutions, we have to start with the idea and the challenge that depression has no magic bullet solution. It's very common, but the way that people get better can be very varied, which is nice on the one hand that there are many solutions, but it's challenging in that how do you choose, right? So remedies that have worked with my clients in my practice include having the boldness and the assertive communication skills to tell their prescribing psychiatrist or whoever's prescribing their antidepressant that they are indeed having sexual side effects. To do that without blushing, to do that boldly, and to kind of say, you know what, doc, got some sexual side effects here, and not feel like that's something you have to keep secret. I've seen psychiatrists prescribe Wellbutrin, which is the name of a drug, I think it's international, but certainly in America, into their regimen, which can have the effect of mitigating sexual side effects. I've seen that happen. Another solution via cognitive therapy is to really explore the risks versus the benefits of having improved mood and functioning, such as in your work and in your relationship, but at the cost of some diminished sexual capacity, and what that might mean for the client existentially in their quality of life if they really have to choose. Another solution is to identify what still works in their sexual repertoire. Maybe they're more bottom anyway, so erectile dysfunction or delayed ejaculation as side effects can have somewhat less impact. And there's still a lot of sexual fun to be had with sexual partners, either a domestic partner or spouse or a trick. Other options might include changing expectations in sex and challenging this pervasive societal idea that the only legitimate sex is fully erect, penetrative, to mutual orgasm with perfect timing, all tidy, all that, and instead might be about more intimate sexual play, using your hands and your mouth or toys or bondage equipment or sensual tools, in kink play, ice cubes, hot wax from a candle, feathers, metal pinwheels, which is a sexual toy websites might sell, flogs, electroplay devices, cosplay, role play, certain foods like whipped cream or chocolate sauce or something. It's about the playful quality time spent with a partner, which can be rewarding and fun and build intimacy or just fraternal bonding if you're tricking. So sometimes the use of an ED drug can help, such as Viagra, Levitra, Cialis, or the injectable compounded trimix or quadmix formulations. It's important that these solutions be learned through patient education by the MD, a psychiatrist, a urologist, an endocrinologist, or it can be from a therapist if they have some qualifications to talk about kind of medical-ish things. But the solutions need to be identified and implemented and evaluated. How is this working for you? And then re-implemented, maybe with some changes or with some customized adjustments. Troubleshooting sexual side effects is really an ongoing monitoring thing, and it can include some trial and error strategies that do require patience. So you bring that concern to your prescribing doctor for your antidepressants, and then let him or her talk about what might be some of the strategies for mitigating sexual side effects, but making it you asserting your right to make that a relevant conversation. And if they blush and say, well, I don't know about that, then get another doctor. If they're an MD who's sophisticated enough to prescribe antidepressants, they should be sophisticated enough to have a mature conversation about troubleshooting sexual side effects. This is not middle school. So number 2, anxiety. Disorders such as general anxiety disorder or specific phobias, panic disorder, adjustment disorder with anxiety, which is kind of a stress management diagnosis, and other diagnoses can have their influence on sexual health. This is probably the most common complaint that I hear from clients. It's about anxiety around performance anxiety, which can certainly affect erectile dysfunction. I had a previous blog article and podcast episode on erectile dysfunction, cognitive causes and cures. And you might want to look that up, because when we apply cognitive therapy to erectile dysfunction, there's some real discussion there. Anxious thoughts in sex can include a lot of what-if statements. What if I don't get hard? What if I don't climax? What if I'm not big enough? What if I have a sexual hygiene accident in bottoming? What if he asks me to do something I'm not ready for, like fisting or bondage? Lots of bad things happen to our thoughts and emotions the second we say what if followed by a negative statement. Now the antidote to this is immediately following that with a what if statement followed by something positive. Like, what if I just relax and improvise and then this ends up being totally fun and I learned something new today? You can follow up a what if statement with a positive scenario just as easily as you can say what if with a negative one. So what are the solutions with anxiety? Anxiety is a disorder about emotionally and cognitively overestimating the risk of harm in something or the risk of loss. It's a function of our psychological defense mechanisms, which is just one part of our minds trying to protect us from a threat it thinks is dangerous, but our rational mind knows better. So we have to learn to talk back to anxiety. In your head, you say, hey, anxiety, thanks. I know you're trying to protect me, but hey, I can handle this. Back off. Really, I got this. It's a cognitive intervention that you do on yourself. Another exercise for anxiety is called grounding. You orient yourself to where you are. Check in with your senses. Where am I? What do I see? What do I smell? What do I hear? What do I taste? What do I touch? This can help you to get out of your head, a term I hear a lot. Oh, I got all in my head about my erectile functioning. Especially regarding anxiety about topping. And there's a previous episode and blog article, gaytherapy.com/blog, of overcoming fear of topping. And a sister article to that, overcoming fear of bottoming. Some guys have some of both and might benefit from how you overcome those fears of topping or fears of bottoming, particularly if that's your preferred sexual role. So coping with anxiety is resetting our internal alarms and realizing that something that our lizard brain thinks is a big deal is actually small stuff that you don't need to sweat. Sex is supposed to be fun, not some kind of anxiety endurance test. Let's work to keep it that way. Number 3, obsessive compulsive disorder, OCD. This is the one that sitcoms and comedians love to have lots of fun with and make fun of, but it's really a very serious disorder. I have a history with it. My symptoms are now what's called subclinical, but me in middle school or an earlier time of my life, and unfortunately I had a big dose of it, so I really feel for people who struggle with OCD. It's really a form of anxiety. It's in the family of anxiety-based disorders because it plays on fears and makes them irrational. So just believing that something bad will happen if you do or don't do something completely unrelated to the situation. The old nursery rhyme, step on a crack, break your mother's back, so you don't step on any cracks on the sidewalk. Your mother's back and then whether you walk on cracks on the sidewalk are completely unrelated. But in OCD, that gets mixed up, and we have an anxiety about that. So recently, my client, let's call him Jason, was exploring how his long-term OCD was affecting and manifesting in his sex life, particularly a fear of erectile dysfunction and being embarrassed when he was with his boyfriend. And in his individual therapy in his home state, his therapist helped him as an OCD specialist more broadly. But in his life coaching with me, we talked about options for understanding how the OCD, which had originally manifested in more traditional ways, was now encroaching on his ability to relax and enjoy his sex life. And that can happen in OCD, where the neurosis or how it manifests can shift from one topic to another. And it was about what to refocus on in sexual situations to bring it out of the anxiety and into the fun of the empowered adult. So what are some solutions here with OCD? So Jason got a lot of mileage out of the 5 senses exercise, as well as more profoundly accepting himself as a proud top in gay sex and validating his right to exercise this, including some dominance, of course, with a consenting partner. Like many anxiety interventions, practice helps reduce symptoms and helps you become desensitized over time to the threat. It's important that in the mainstream discussion of OCD treatment, such as exposure and response prevention techniques for compulsions or coping with intrusive obsessive thoughts, that the sexual aspects be made okay to discuss, without stigma or fear of rejection from a mainstream psychiatrist or psychotherapist. This is what we call an access to care and patients' rights issue, as all gay affirmative medical and mental health care should be. It's not, but it should be. And sometimes as patients we need to insist that we are receiving gay affirmative medical and mental health care whether they want to provide it or not, because it's our right as a patient to be treated equally as minorities in society. So number 4, let's look at attention deficit disorder in adults. It's also called attention deficit hyperactivity disorder. This diagnosis is a little controversial. There's some people who say, ADD doesn't exist. It's just people being neurotic. I think that's very dismissive. I think there's all forms of severity in adult ADD, and I think it's really a thing, definitely. I see it a lot in my practice, and these guys need validation for that. It's not a bullshit disorder. It's a diagnosable disorder. And this affects many of the gay men I work with so much that I wonder if the neurobiological aspects of both ADD and OCD, which research shows are associated with the amygdala, a mechanism in the brain, are not somehow overrepresented in gay men. Who knows? Research and time will tell whether the gay men are more vulnerable to ADD or OCD. ADD in relationships can happen. I have an article on gaytherapyla.com/blog. I'm going to keep plugging that URL. Is about ADD in relationships, called ADD and OCD in relationships, about what it's like to be the partner of somebody with ADD or OCD. And sure, the presence of these in a relationship presents challenges, but it's not insurmountable with, communication and what we call adaptive coping behaviors. It's learning to live with ADD or OCD in your house, in your relationship. But, ADD-type distractibility in sex can make your partner feel devalued, that you're not in the moment with him, and that might make him possibly feel annoyed or abandoned. So guys with ADD might also need more or different stimulation in sex in order to have fun. Psychological research shows that some people are just more stimulation seeking than others. Think of roller coaster fans or extreme sports enthusiasts. There are published psychological tests for this called psychometric instruments. It's a fancy name for kind of a survey. But, that measure this, what we call sensation-seeking behavior. So what's the solution for this one? The same cognitive behavioral therapy approaches that help generic ADD symptoms can be modified to apply to your sex life. Maybe your partner knows how to redirect and refocus you to the activity at hand, meaning sexual play. Maybe the person with ADD is especially suited to group scene play or being all over the place in a fun way at a bathhouse or a sex club where there's lots of stimulation and lots of partners and lots of stuff going on. Just a little bit of incorporation of the sexual concerns and aspects of ADD treatment will go a long way in validating the person living with ADD, the gay man living with ADD, in this kind of 360-degree way for a more comprehensive approach. Because let's face it, people with ADD or any psychiatric disorder are still consenting adults who have sexual appetites just like normal people. That's being facetious there and a little sarcastic. But it's a joke I like to use to illustrate how people with psychiatric disorders of any kind can be stigmatized and robbed of the expectation that they have normal drives for life, liberty, and the pursuit of happiness as anyone else, including sex. But too often, all psychiatric patients, straight and gay, are infantilized as these eunuchs just because they have everything from a mild to a severe psychiatric disability. You don't forfeit your consenting adult right to a healthy sexuality just because you have a psychiatric disorder. It's the same way with the elderly and how they're treated in nursing homes where they couldn't possibly be having sex because they're 80. Well, lots of 80-year-olds have lots of good sex. And in institutions and medical practices and nursing homes and group homes that deny this are really denying the human rights of people with disabilities to have sex. That's true also with physical disabilities, like people who are paralyzed. Lots of people who are paralyzed still have dicks that work. That's kind of a thing. And, ableism needs to be challenged on this idea. And we want to incorporate sexual access and sexual dignity into the treatment and the resources for people living with disabilities, including psychiatric ones. So number 5, let's look at PTSD, post-traumatic stress disorder. The sexual mental health of gay men living with PTSD is an especially poignant topic in my practice because I work with survivors of sexual assault, childhood sexual abuse, rape survivors, combat injury, gay soldiers, vehicular accidents, sports injuries, even a chronic illness like HIV or lupus or MS or all the others can have kind of PTSD symptoms in the aftermath of a traumatic event or series of events. And the partners of gay men with PTSD need to be especially patient so that sex with their partner doesn't cause triggering or re-injury. I always say that the number one most important concept in trauma recovery is reclaiming, which is reclaiming the life and the outlook and the functioning that you would have had your perpetrator not indulged themselves in their narcissistic antics that harmed you in the first place. Now that can be a person who committed a violent crime against you, or it could be nature in terms of a natural disaster or an accident. But especially when it was an interpersonal crime like rape or abuse or assault, that's especially important to reclaim away from them and take your power back with the quality of life that you would have had the trauma not occurred. So you have a right to enjoy an adult, satisfying gay male sexuality, just like gay men who are not trauma survivors. Slowly and carefully reclaiming your sexual repertoire, orally, anally, manually, all of that, to celebrate you and your partner's bodies. You know, that's an important part of recovery, and it's a big fuck you to your perpetrator. That he or she didn't knock you down permanently, you get right back up again, including up in that way. So what are some solutions? So PTSD has many popular treatments. You know, trauma-focused cognitive behavioral therapy is one you might hear about. Eye movement desensitization and reprocessing, EMDR. I think that's a little overused. It's a little bit trendy and hype, but it is what we call evidence-based practice. Research has shown that that's a legitimate treatment. It's not just malarkey, unlike sex addiction treatment. And then, of course, there's the psychodynamic techniques. You know, psychodynamic psychotherapy is a little older. It's a little old school, but it's enduring for a reason. It's because it can certainly work. And all of these things can work. Seeking safety can work. There's just a lot of different psychotherapy models that can be applied to help people with PTSD to overcome or at least reduce their symptoms. So my concern is that many of these approaches can overlook that recovery from PTSD and reclaiming, that word again, your optimal functioning includes your sexual functioning, and this may or may not be addressed in mainstream therapy, especially if we're talking about how gay men can enjoy giving oral sex when their perpetrator orally violated them with an adult penis or a foreign object. You know, these kinds of sensitive considerations need their own discussion to validate more specifically the gay man's PTSD recovery experience. Techniques might include going at a very slow pace with your sexual partner in oral or anal sex, discussing if and how you might be triggered by certain movements or physical experiences, and in the moment reframing the stimulation from alarming, such as what happened during the abuse or trauma, to pleasurable, with the adult prerogative to do what you want with your own body with another consenting, keyword, adult. Number 6, body dysmorphic disorder. Little lesser known disorder, but it's still there. So another challenge for gay men is when they have body dysmorphic disorder, and possibly an eating disorder like bulimia or anorexia would be in this. You know, gay men are overrepresented in eating disorder diagnoses over straight men, and it's theorized that that can be a cultural influence. So BDD, or body dysmorphic disorder, can psychologically distort your own perception about your appearance or your body or a part of your body. It's a very puzzling phenomenon. Many people have discussed how sociocultural pressures on cisgender women worldwide, but especially in Western countries, can lead to women feeling bad about their figures and what they're supposed to look like from being bombarded with media images and fashion influences, thin, big tits, all that stuff. And similarly, gay men can feel like they're being judged for how they look, sometimes by others, but often just by their fellow gay men. The pressures to look young, or trim, or twinky, or muscular, or aesthetically hairy, or hairless, and overall fashionable with what you wear. Those pressures can get intense. Look at social media like Instagram or TikTok. What do these guys look like? What are they wearing? What is their appearance? And some say that BDD is related to OCD in that it can feel like an obsessive preoccupation with minor flaws. Anxiety about having a big nose or a small penis or even small calves or thinning hair can all be examples, from a minor case of anxieties to very severe and obtrusive obsessive thoughts. Guys with these feelings might not feel good enough to present to a partner for sex, and then their sexual mental health is impaired and their quality of life for feeling socially and sexually isolated. So, what are our solutions here? Disorders like OCD and BDD have been known in research to respond well to cognitive behavioral therapy, but they take time and patience for both clients and their therapists. And deep-seated negative beliefs about the self can take a while to untangle, because they came about as a result of constant bombardment that gay boys and gay teens and gay men get about being less than. We see it everywhere in politics, especially in Republican politics, about don't say gay and don't do this and blah, blah, blah. Trans people get it too. And, and not to overlook lesbians, because they take a lot of crap from conservative politics as well. But acknowledging the cultural context and the pressures that specifically gay men face can be an important part of treatment, because we live in the person and environment setting. I used to teach this when I taught it at USC in social work. In social work, we talk about the person and environment. There's your intrapsychic goings on, and then there's the environment and the culture and the time and history in which you live. And we're interacting between the person and environment constantly. The person can change the environment, and the environment can change the person. If gay men were coping with anxieties 100 years ago, they might feel very differently, because they weren't bombarded with constant images of the idealized male physique through mainstream media and social media, as well as porn. Applying critical thinking like Instagram is not real life can be important to keep perspective, as well as validating that the legitimate gay male experience is not limited to some kind of idealized physique or appearance or luxurious lifestyle. Just like we need to validate gay men's experience that they're not any less legitimate just for being gay, they are also no less legitimate for being outside the social media ideal of what gay men should look like. There's a certain amount of angry defiance that is important here to resoundingly reject pressures and validate your right to be who you are. Now, if you want to be involved in bodybuilding or physique sculpting or yoga or sports of any kind, that's different. That's an empowered choice that comes from you and your interest and your values and your health plan. But we should never be a slave to fashion unless fashion is really fun for us. It takes a lot of self-reflection and critical thinking to differentiate these, and I think too often gay men don't have that kind of encouragement. So as a leatherman myself and as a biker, I've been labeled weird more than once, including by my fellow gay men. And I'm okay with that, because I'm having fun with that. That's my personal style. That's my interest in motorcycling, or that's my interest to be part of the leather community by expressing who you are by what you wear. Drag queens would be the same way. I think it's fun, but I realize that that's what's okay for one person is not okay for another, even among gay men, and that's okay. So number 7 is personality disorders, and these are a big group because there's about 9 or so personality disorders, and we won't go into all of them here. But, this category of DSM-5 based personality disorders, it's too broad for any one discussion, but on gaytherapyla.com/blog, I have a 3-part series of previous articles on personality disorders in the workplace. and how they affect gay men's professional lives. And that, just look up personality disorders on gaytherapyla.com/blog in the little search box if you're interested in learning more about how personality disorders manifest in the workplace for where gay men work. But when personality disorders of all kinds, there's 3 big categories, affect gay men's mental health, they might include some of these. So let's look at a few. Narcissistic personality disorder. We all know gay men who are vain or self-involved or non-empathic or obnoxious. This is often seen as a psychological defense against feeling small or less than. And while it happens, to straight people all the time, Donald Trump, the leading example, for gay men, it can be a response to being belittled in early childhood. It's theorized that personality disorders, you're not really born with them. You might be born with a vulnerability to them, but they happen at about age 3. It's part of psychological development in the child. And they're not really considered biologically based exactly. There's debate on that sometimes, like other psychiatric disorders, but they're more developmental, and they affect interpersonal relationships in a certain pattern of behavior toward others, at work and at home. A personality disorder can only be diagnosed if it's very pervasive through different settings and throughout the lifespan. So another one's borderline personality disorder. Some of you know all about that one. But this disorder can be in the aftermath of trauma, where a person has a chaotic personality structure or organization, that includes a lot of turbulence, a lot of drama, intense fear of abandonment, and a sense that nothing you do to reassure them or help them is ever enough. They feel like you're talking to a bottomless pit. And this might manifest sexually as lots of frequent and superficial sex, or hot and cold relationships, or manipulation, or I love you, I hate you dynamics. Just a lot of personality, what we call lability and instability. Schizoid personality disorder is another one, where someone generally avoids people, and that might create the asexual identity as a general avoidance of interpersonal sexual relationships, despite having a natural biological sex drive. The antisocial personality disorder, this is also known as a type of sociopath. The sexual connection can be severely disordered, even criminal, of people who exploit others sexually and victimizingly, such as Jeffrey Dahmer or Ted Bundy, who were 2 very famous serial killers. If someone is involved in something like this, it's often hurtful, from being dismissed or devalued all the way into criminal behavior. And perhaps, this is the worst example of a psychiatric disorder applied to sexuality, because it gets into the violent and the criminal and something that crosses against the mores of society. You could say that about homosexuality too, but I mean in a legitimate way. Antisocial personality disorder is very harmful to people, and you want to avoid people like that, because there's really no winning. If they truly have that disorder, it can be very dangerous. So what are the solutions for personality disorders? Personality disorder solutions are notoriously elusive. It's not so much about treatment, or certainly not cures, as much as some kind of adaptive coping, which often involves intense therapy. Dialectical behavioral therapy is one, especially for borderline personality disorder. Old-fashioned psychoanalysis can help. This is a complex situation of coping and quality of life, and it can be challenging, but still a noble goal of treatment. It's just that your expectations have to be adjusted for the severity of the disorder. Now, this last category, let's look at other, just other psychiatric disabilities. What comes to mind for me is this is autism spectrum disorder. We used to say Asperger's syndrome, but now it's more autism spectrum disorder. The dementias, developmental disabilities, what we used to say is retardation, corporal disabilities, like with the body. So, the DSM-5 is a thick book, hundreds and hundreds of pages. And to catalog the seemingly countless psychiatric disabilities that a person can face, it's overwhelming. And that's just the Western American ones, identified by the American Psychiatric Association. Other culture-specific phenomena exist in other countries and other peoples. So when someone has a developmental disability, or perhaps a neurobiological deficit or injury or illness, such as dementia, much starts to involve patients' rights and their right to adult pleasures such as sex, but also with a careful consideration of consent, which can be impaired with cognitive impairment, and that can lead to an ugly exploitation or victimization of vulnerable populations, like the developmentally disabled or the elderly. So the discussion of what consent looks like with someone with a cognitive or neurobiological disability is really complex. What I think is important is not just to write off people with these conditions as automatically all ineligible for all sexual contact just because they are disabled. It's an important assessment from their care team of what might be ethical in those cases, and what is in the patient's best interest, and who gets to make those decisions. Gay men can be among the numbers of people with such disorders, and my hunch, unfortunately, is that the situation is worse for them than for straight people with the same conditions because of the aforementioned or ignoring or invalidating gay men's sex. So people with disability sex, and certainly with the two combined, if you're LGBT and living with a psychiatric disability, including things like dementia or autism or developmental disability, you've got a compounding situation of what is consent, because easily people with all kinds of disabilities can still have a sex drive and want to use the adult prerogative of being sexual, including the gay ones. And yet that's probably the last population really to be validated about sexual issues in society. So like so much of this, a really careful discussion of ethics is required here, and that's almost never talked about in academic settings and clinical settings, even gay clinics and LGBT centers and stuff like that. So if you or someone you know, such as a partner or a friend, are struggling with the mental health aspects of sexual health, try to move the needle in some way, to move from relative isolation and suffering in silence to being actively involved in care. Get connected to therapy or coaching that's gay affirmative and psychiatrically affirmative, and that might help to reduce the negative impacts of a psychiatric or psychological disorder on your sex life, and by that, your overall quality of life. So for more information on me, gaytherapyla.com, on my therapy or coaching services, feel free to email me, ken@gaytherapyla.com, or you can also text or call me in the United States, area code 310-339-5778. Thanks, and I'll see you next time.